Everyone. It is my great pleasure to welcome Professor Lisa Bortolotti to the Egenis seminar from the University of Birmingham. Lisa has done lots of work on lots of things. She's really world-leading in the field of philosophy of delusions. In 2010, she wrote a hugely important book titled "Delusions and Other Irrational Beliefs" that was very influential to my thinking on delusions in particular, but really brought delusions to the center of a philosophy of mind and epistemology. And last year she published another book entitled "Why Delusions Matter." That's really excellent. I highly recommend it. He also works on all sorts of sort of socially engaged philosophy at the intersection of philosophy of medicine and philosophy of psychiatry. And she works on is a co-I on the project on the epistemic innocence in healthcare, the EPIC project, which is across Bristol, Birmingham, and Nottingham. Yeah, so without further ado, I'm gonna shut up and welcome Lisa to the floor.
Thank you, Sam, for a very nice introduction, and thank you for inviting me. It's really nice to be here. So it is a fairly new paper for a fairly new project, I think. And so yeah, be kind to me, be gentle. Here, what I'm trying to do is look at arguments suggesting that we should promote epistemic injustice in the context of healthcare interactions, not just for moral reasons, because it's a nice thing to do, because we want to make sure that people feel listened to and understood, but also because those healthcare interactions won't achieve what they're meant to achieve unless the patients can contribute meaningfully to the epistemic project that goes on in those interactions. So it's a way of furthering the goals of a clinical interaction. So almost like medical reasons to promote epistemic injustice. So the plan for this talk is to tell you a little bit about what epistemic injustice is. Imagine some of you might already know, but just to have a starting point and to move to considerations about agential epistemic injustice, which is a notion that has been developed by Posa Medina, and telling you why I think that this is a notion of epistemic injustice that is more interesting to apply to the case of mental health. And then give you some reasons to think that avoiding agential epistemic injustice is good medicine, not just ethical behavior. And my considerations are at the moment falling under two categories: the knowledge exchange argument. So without epistemic justice, what happens in these healthcare encounters is that there is insufficient knowledge exchange. And the motivation argument that without epistemic justice, what happens is that patients are not motivated to contribute to their health journey in the way in which the epistemic encounter suggests. And then give you some conclusions and implications. Okay, so what is epistemic injustice? In the philosophical literature, epistemic injustice was introduced by Miranda Flicker as a phenomenon at the intersection between epistemology and ethics. And the idea is that harm is inflicted, wrong is done to a person in their capacity as a knower when what they have to contribute epistemically is dismissed because of a negative stereotype associated to that person's identity. So an example would be dismiss a woman's contribution to a political debate by saying, oh, by the way, women don't understand anything about politics. We might not say this explicitly, but if there is this prejudice, then what happens is that the credibility and authority assigned to the speaker becomes much lower when the speaker is a woman in that context, and so on. And there are lots of interesting examples that have to do with gender and have to do with race in Miranda Fricker's original book. But since then, a lot has been said about the importance of thinking about epistemic injustice in the healthcare context, and nobody has done more to pursue this agenda than Avi Karal in Bristol, who is the principal investigator of our project, a Wellcome-funded Discovery Award project, which looks at identifying potential cases of epistemic injustice in a number of case studies. Some, the ones that I'm in charge of, are about mental health, but there are lots more. And also kind of test epistemic injustice, or get some empirical data and see whether actually those situations that we might be tempted as philosophers to call epistemic injustice actually involve those harms that we have in mind in that context. Now, we are very interested in EPIC, and I'm very interested personally in being able to bring the work that we do in the project to everyone, and in particular to make it accessible to healthcare practitioners, because the idea is that whatever comes out of EPIC will have to be used to improve the training of healthcare practitioners, especially in clinical communication, but potentially in other areas. And also making people aware that epistemic injustice can happen, because a lot of people feel uncomfortable when they go and see doctors, but they don't exactly know what's wrong, or they cannot put their finger on what it is that is happening that prevents them from feeling engaged or empowered in those contexts. So we are also creating resources for the general public, and I'm just going to give you an example. It's a 90-second video that we created to show what epistemic injustice is. It's not particularly applied to the healthcare context, but it's showing that sometimes dismissing someone's perspective can be an act of injustice, or this happens when there is a prejudice against an individual due to aspects of their identity. And what really mattered to me when I was scripting this video was to highlight that if it is epistemic injustice, there are costs, potential costs for the person who is not listened to, whose perspective is dismissed, because of course they don't make a genuine contribution to the exchange. But there are also costs for the person who is dismissing, who is not listening, or is not paying attention, because there is knowledge that may be helpful for them that is not taken up, that is not available to them. And the other thing I wanted to show, but that's again super implicit, you have to read between the lines, is that epistemic injustice can happen interpersonally, so between parent and child, or teacher and student, or employer and employee, but it also has some cultural dimension. So epistemic injustice can be enabled by the culture of certain institutions. So I'll let you watch this video. I don't think.
Oh, sorry, it's not sound.
No. We tested it before.
Oh, please.
Is it because of the Zoom? Okay, it doesn't matter if it doesn't work. I can tell you where to go and look at it. It's on the Philosophy Garden, so philosophygarden.com. And basically it's a story of the fawn spotting a mountain lion while his family is going to get water at a water hole, and telling the stag, so his father, that there is a mountain lion in the area, and his father replies saying, oh, come on, if there was a mountain lion, I would have heard the steps. Clearly there is no danger here. The mother says, but are you sure fawn has never lied to us before? And he says, oh, the young ones are dramatic and open to confusing imagination and reality. And we put those words on purpose because when we're looking at youth mental health, a lot of the negative stereotypes towards people who are young and have mental health issues are that they are drama queens, and they make fuss about things that they shouldn't be, and that they're not capable of understanding how things are in reality. They make things up. So we wanted those two stereotypes to be in there. Anyway, to make it short, at some point the mountain lion attacks the stag, and so there is a cost also for the stag was being dismissed in the fair warning. And the doe talks about how in the herd, which is a very hierarchical society, your society, only dominant males have power, and fawns and does are routinely dismissed and not listened to. So that was it. I let you go and look at it in your own time. In particular, I'm interested in the notion of agential epistemic injustice. So Medina's notion is that he's looking at a particular kind of epistemic injustice that doesn't necessarily manifest as silencing, right? But it may actually be such that it requires the person who is a victim of epistemic injustice to actually contribute to the interaction. It's just the way in which the way in which the contribution is received is such that the contribution is constrained, manipulated, or distorted. So there is a contribution. It's not like silencing. You don't have a voice. Your voice is heard, and sometimes your contribution is solicited, but the way in which other people receive this contribution makes it the case that it is not received in the way in which it was conceived by the person making the contribution. And I'm going to give you 3 examples of agential epistemic injustice because it can take different forms in different contexts. So a famous example is by Chris Fuquay, and it's contributory injustice. So the interpret reconstrues the speaker's contribution based on the assumption that the speaker is incompetent, right? And the example that he uses is a philosophy class, and there is a discussion, and there is a student from a marginalized group who raises his hand and makes an objection. But actually, the teacher reinterprets that objection as a request for clarification. So it doesn't receive that objection as an objection on the assumption that the student does not have the knowledge or skills to come up with an objection. So in a way, nobody is being silent here, the student asks the question, but the way the question is received is not the way in which it was originally conceived, and that's due to a prejudice. Another case is harmful inclusion. So a person belonging to a marginalized group is asked to contribute to an epistemic project, for instance, fill gaps in societal understanding of exclusion and discrimination. And Paul House has this example of, for instance, a person belonging to a marginalized group is asked to provide evidence that the group is being marginalized, that there are behaviors that are to be changed to increase inclusion and equality in a certain environment. But the way the information is gathered from these members of the marginalized groups and integrated prevents actually their perspective from being accepted as it is. And a classic example for us, it would be familiar to some of you. If you're a woman in a philosophy department, you will be asked constantly about what can be improved to make the environment better for women. And then you get into a cycle of things for which you're constantly asked for evidence that things are not going the way that you would expect them to go if there was equality and acceptance of diversity and inclusion. And it's very, famously very difficult to provide evidence that these things are happening because the kind of standards of evidence are extremely high. So it's very labor-intensive job for the members of the marginalized community to provide this evidence, and the perspective doesn't come across. Once this evidence is gathered, it's packaged in ways that make it easier for the institution to meet the demands, and is not actually something that reflects the concerns of the people involved. So that would be a case of harmful inclusion. There are interesting examples in the mental health context too. I'm not going to talk about them, but a lot has been done on illness narratives and how they're used. Angela Woods, for instance, has done a brilliant job showing that sometimes asking people who have lived the experience of mental illness to provide their own narratives of what has happened to them in order to eliminate stigma is actually quite harmful, because the way in which their narratives are packaged is always like, oh, I was in a very bad situation, then it got much better because of this medical intervention, and now, I'm good again. And that's sometimes not how people feel about how things go. So it's a really interesting notion, harmful inclusion. And the last one is extractive testimony. This is the most dramatic one. So the contribution of the speaker is sought, but valued only when the agency of the speaker is completely annihilated. As in confessions obtained by force or torture at the Salem witch trials, for instance, when if people thought you were a witch, then if you were spontaneously saying something, you were lying. But if you were saying something under torture, then you'd be telling the truth. Right? So your contribution was sought, but it was received as a true contribution, truthful contribution, and important contribution only in conditions where your agency was being seriously undermined. And there is another good example, a recent fact, I think in New York, Central Park, where two young people of color accused of raping a young woman, and being interrogated by the police up to the point when they confess, and actually that they weren't implicated in the rape. But this idea that they're saying the truth only if we are asking them in a certain particular way, but basically repetition and pressure. So again, if they say spontaneously, we haven't done it, we don't believe them. But under this kind of coercion, we suddenly, all of a sudden, think that they're telling the truth, right? So these are all very different cases, but they're all cases where people are not denied the contribution, but the way the contribution is taken is very different from how they offer it. And this is my observation of all of these different cases, that in this kind of epistemically unjust interactions, the successful fulfillment of the key goals of those interactions is compromised by the epistemic injustice. So in a good philosophical discussion, what we should be doing is not dismissing objections or intending them as a request for clarifications, but addressing the objections, right? That is where the discussion becomes good. It's not a good philosophical discussion if we, sweep away all the objections. It's not conducive to making progress with inclusion if we gather and package information about discriminatory practices in a way that distorts the perspective of the people who are subject to discrimination. So if our goal is to achieve more inclusive and more diverse environments, we are not meeting that goal. And forced confessions needed to truth, not to justice, right? So if that's what we're looking for, it's very debatable that the people involved in those processes were looking for truth or justice, but if that's what we are supposed to be looking for, then the extractive testimony doesn't work that way. So my hypothesis is that this is true also of epistemic injustice in healthcare interaction. The speaker needs to be able to make a genuine contribution to the interaction to have the desired effects, to meet the goals that the interaction has. So if the goal of the clinical interaction is to improve outcomes for people who are struggling with their mental health, then epistemically unjust practices are an obstacle to achieving that goal. And you may wonder why, given that epistemic injustice was created to make this an ethical issue, I'm going back to make it not an ethical issue. And the reason is that there is a lot of pushback against talking about epistemic injustice in the healthcare context. Last year, a paper was published by Kayes and colleagues arguing that epistemic injustice has no place in psychiatry and it makes for worse medicine. So I think it's very important to be able to have an answer to that kind of issue. We'll get to that a little bit later. Okay, so now the part comes when I give you some examples of interactions in a mental health care context where I think we have good reasons to invoke epistemic injustice. So in the case of serious mental illness, such as schizophrenia, for instance, or dementia, the assumption is that the capacities to produce and share knowledge and to behave in agentic ways, to be an agent, epistemic agent, are entirely compromised. I'm not saying that this is what happens in those conditions. I'm saying it's what people assume in those situations. And that could only be the case because otherwise we couldn't justify what happens to people with schizophrenia and dementia. So there is a lot of disengagement. There is a lot of exclusion and coercion that might happen with patients with those particular conditions that would not be acceptable if we thought that those capacities were intact, right? If we thought that they could produce and share knowledge and behave in agentic ways, we would not have the practices that we have. So mental health patients may face the following situations, and I'm sorry, this didn't come out well, but it's just some evidence supporting this point that they are being devalued as testifiers in healthcare interactions. So they provide a testimony about their own experiences that is not listened to, or sometimes just considered to be untrue. They are experiencing clinical communication as a confrontation, so it's never a dialogue where people contribute, but it's more like they propose something and this something is being challenged. Their testimonies are edited when they're not challenged, so what they say is being reinterpreted by the practitioners. They're being excluded from key aspects of the encounter, such as the choice of the most appropriate treatment option. So things that people describe, for instance, young people will hear voices. We worked with a group of young people from the Voice Collective, and they were describing being in a room where the practitioner was talking just to their parents. They wasn't even making eye contact with them or asking them how they felt about potential choice of treatment option. People with dementia, even in the very early stages of dementia, when their capacities are almost intact, find the same that when they go and see healthcare practitioners. Often the healthcare practitioner addresses their care, but doesn't address them or doesn't ask them questions about their preferences. Okay, so I did have another video which I'm not going to show you, but this is something that we did together with the people from the Voice Collective. These are young people from 16 to 25 who hear voices and have unusual beliefs. We worked with them in a series of 7 workshops, and they came up with a script for a video where they share what they think is harmful about the expectations and assumptions that people have. They identified 3 types of prejudice or assumption that people have towards them: that they're dangerous, that they're incompetent, and that they are too different to be included in certain types of social interactions. And they describe in the video what is it that this implies for their lives, basically the cost that this has. And again, you can go and look at the video if you're interested. I'm going to now describe 2 snapshots of interactions between young people who accessed emergency services, mental health emergency services in the UK, and healthcare practitioners. These were interactions that were video recorded. I'm not allowed to show the recording, especially when we are online. But I'm going to share the transcripts of some of these interactions. These are not very pleasant interactions, so I'm just going to warn you that there will be discussion of low mood and suicide. Okay, so the first one is Patrick, so a young man. Patrick is not the real name, of course, so that's what he says. So I feel like miserable kind of sums it up. Yet in your face, yeah. When you're speaking, you've got a variation, haven't you, of your expression, and you smile and things like that. Yeah. So you have time when you clearly aren't miserable, you're sort of enjoying things. You're able to give the impression that you're enjoying things. Yeah. What plans would you have had if I've got a few events on, because I'm part of rugby, skiing, and tennis, and they were all putting events on tonight I couldn't go to. I see. So could we safely say, you wouldn't have your life or done something that would have, what, tonight? Yeah, no, I wouldn't have ended it tonight. You wouldn't. Okay. So maybe there was a bit of miscommunication because they brought you here saying you were suicidal. No, I am, but you are? But I feel I can, I haven't done it yet. So the background, Patrick is referred to mental health emergency services from university counselors after he contacted counseling services because of his mood and having suicidal thoughts. He's asked at the beginning of the interaction how he feels, even before the transcript that we saw, and he describes himself as miserable and suicidal. So what you see in the interaction, which was analyzed with people who did conversational analysis, basically what they do is they look at the transcript But they also look at the video. So they look at the verbal and non-verbal cues, at the gaze, where kind of the body, the way people kind of dress each other, whether they are facing each other or not, whether they look at each other, and the poses and everything. And in the analysis, what seems to be very clear, and this is common with all the interactions that we saw of this type, is that a young person stops engaging with the healthcare practitioner after they've been repeatedly challenged. And you see that Patrick becomes a lot more hesitant in stating what he thinks is happening and in contributing something after he's been challenged. So Patrick's report is challenged by the healthcare practitioner, who suggests that Patrick does not look miserable. I know you smile and things like that. Given his plans to make some friends that night, he thought he did not genuinely entertain thoughts of ending his life. So could we safely say, you know, you'd end your life? And this is interesting because this leads to some kind of delegitimization of Patrick's attempt to seek help, because at some point the practitioner says there must have been a misunderstanding, you shouldn't be here if you were not genuinely suicidal. So Patrick gets to talk about how he feels. It's not silence. He's even asked questions by the practitioner. He's asked about his mood and his intentions. But Patrick's reply is not taken at face value. So when he says, I'm miserable, the healthcare practitioner does not say, oh, yeah, you think so, why? You know, why do you feel miserable? It doesn't explore Patrick's report, it just challenges it. You don't look miserable, you're smiling and things like that. And there is no time to further explore why Patrick says that he feels miserable and suicidal. So the practitioner does not at any point ask Patrick to elaborate on how he feels. At the end of the interaction, the practitioner hints that Patrick may be wrong about how he feels, given how he looks and behaves, and there is a suggestion that Patrick might not have been unwell enough to be sent to emergency services. Patrick is advised to visit the self-help website and continue accessing his university counseling. No further support is offered. We'll get back to Patrick in a little bit, but I want to give you another example. This is Sasha. Because my obsessive behaviors have been getting worse and worse as well. They've now kind of spread into areas of my life, like eating. Yeah, Steve said that he was really concerned about the weight I've lost so rapidly, and I can feel my heart slowing down, and I can feel the physical symptoms from it. And in terms of your understanding, what's your diagnosis, Sasha? OCD and anxiety, I think. Okay. And for you, that makes sense, does it? Yes. The only thing that doesn't make sense is why I'm feeling unable to eat and restricting what I'm eating. Okay. Having kind of unpleasant thoughts about my body shape. Okay. That. All right, okay. And I assume that you're really trying eating, as in you are, trying to give yourself permission to, enjoy food, whatever. Because I guess if you're quite slim and you're worried about losing more weight, now is not the time to start thinking, well, I shouldn't have any custard, or I shouldn't have any. So you're trying. Are you trying? Just have what you fancy when you could eat it. Again, it's easier said than done, but whatever it is, it's not letting me. It's not what? Sorry? It's not letting me. Right. Okay. Like I haven't eaten anything today. And I've barely eaten anything since Monday. Just, okay. Yeah, it's got out of control. Okay. Okay, the background. Sasha accessed emergency services due to symptoms of OCD worsening, involving self-harm and suicidal thoughts, but she's mostly worried about her food intake. Sasha feels that her OCD requires her to restrict her intake to 800 calories a day. She claims to have lost a lot of weight and is now close to being underweight. So there is difference between the way the young person talks about their eating and how the practitioner talks about their eating. So Sasha presents it as something that she cannot control, whereas the practitioner talks about it as something that can be managed. So Sasha refers to eating as something that she cannot do. I'm unable to do it. It is out of control. It is not letting me. The practitioner talks about it as if, if she really tries, maybe she could just eat a little bit more. Just have what you fancy. When it's time for the practitioner to propose means of support for Sasha, the implication is that the problem is not a serious one and that it will be sufficient for Sasha to ask someone to sit with her at meal time. So Sasha talks about Steve, her boyfriend, a few times. And the practitioner at some point in the conversation says, oh, you can just sit with you when you're eating and tell you to eat if you don't eat. Whereas Sasha would like to get specialist support with her eating, to the practitioner's self-help and support from friends and family are sufficient at this stage. Okay, so these come from a study that we did on agency-induced mental health that was supported by UKRI. And we had a number of recordings of a number of exchanges. A lot were much better than this. The interaction went much better. The practitioner was listening and interested in providing support. But we thought these were two cases in which this didn't go, which the interaction didn't go very well. Also because as part of this study, the young people involved were interviewed immediately after the encounter and then a few months later. And when Patrick and Sasha were interviewed immediately after the encounter, they said they didn't feel the encounter went well. They were not happy with them. So what happens here, they might make us think about agential epistemic injustice. The young people participate in the exchange, although the kind of participation is interesting. So again, when the young person talks about something that the care practitioner doesn't think is important, there is no engagement. You saw with Sasha, the practitioner would say, a lot. No question, no kind of tell me more, nothing like that. Also, the participation in the exchange is challenged and reconstrued according to the practitioner's own understanding of the situation. So if they don't think, it's a real kind of case of people having suicidal thoughts and being miserable, they re-describe them as not being miserable. If they don't think there is a serious eating disorder problem, they reconstruct the things that the person is saying slightly differently from how they did. So Patrick and Sasha's contributions are not seen as the contributions of a competent agent, they are reworked and reconstrued. Statements that support the practitioner's view are accepted and integrated in a narrative explanation of the situation, and statements that are in tension with the practitioner's view are challenged and undermined. So as in the case of misinterpreted contributions in the education settings, the contributory injustice, or the false confession in the witch trials, there is pressure exerted by a rephrasing, repetition, and close questioning. Of course, it's not as dramatic as the witch trials, but this kind of questioning is forensic. So the healthcare practitioners seemingly attempt to identify inconsistencies in the patient's spontaneous report. You say you're miserable, you don't look miserable. You say you're not eating, but surely your boyfriend can sit with you and persuade you to eat. So my point is that if we could make these interactions more epistemically just, we could also make this interaction better from the perspective of meeting the goals of these interactions as medical interactions. One thing that might worry us is a recent pushback against the notion of epistemic injustice in psychiatry. For instance, Kayas and colleagues in a Lancet paper argue that it is unreasonable to expect mental health practitioners to always believe what people seeking support say, and the demands of epistemic justice may be clinically unhelpful, pushing practitioners to behave in ways that do not support the health outcomes of people seeking support. In a way, the argument of my paper today is an answer to the second point, but I want to say something very briefly about the first point as well. Epistemic injustice is never about credulity, it's never about believing everything that people say. It's never been. So the demand of epistemic injustice is to take people seriously, to take them as epistemic agents who are making a contribution. That contribution then gets to be evaluated in its own merit, and the interlocutor can decide whether to believe it or not. But when epistemic injustice happens is when the contribution is not even taken to be a serious epistemic contribution due to prejudice that is associated with the person speaking, and usually this has to do with some aspects of their identity. There is no expectation that the interpreter readily agrees with everything the speaker says and accepts all the speaker's reports as accurate representation of an subject. Yeah. And indeed, what we were suggesting when we were looking at the interaction was, why is she not asking more? Why doesn't she ask, why do you feel miserable? How does that make you feel? Can you give me an example? Why doesn't, the experience is not discussed more? We weren't saying, why doesn't she just agree with the patient? That's not the point, right? But that is for another paper. So epistemic injustice is about the assumptions an interpreter makes about the capacity of the speaker to share and produce knowledge. And so in these cases, there is a combination of different types of assumptions associated with the person's age and the person's mental health condition that contribute to creating the impression that the person is. But more important, an epistemically unjust interaction is, I claim, unsuccessful when measured against the key goals that an interaction of that type is supposed to achieve. So epistemically unjust medicine is just bad medicine. A clinical interaction is successful when it leads to understanding the nature of the problem the person is seeking support for, identifying the best means of support for the person experiencing the problem, and enabling the person to use previously identified means of support to address the problem. If epistemic injustice, or what we might describe as behavior that might be described as epistemically unjust, prevents the interaction from achieving these goals, then it's not being medically helpful. So the first point is about information. In order to be able to know what is going on with the person and identify means of improving the situation, we need to know exactly what the experience of the person is. And this is even more important in mental health, where basically the symptom is always something that starts with the person seeking help or reporting something, or someone doing that on behalf of the person. So a genuine exchange of information between a healthcare professional and the person who seeks support enables knowledge about the person's experiences to be shared. Without that kind of first step of listening to what the experience is and asking questions about it so we understand exactly what the experience is like, it's very difficult to do anything else in the interaction. This includes knowledge about the mental health issue affects the person's life, the individual person, because many people are depressed, but the depression manifests very differently. Many people have suicidal thoughts, but again, that affects their lives very differently. So the point of the interaction is to establish how that feels for that person and what the impact is on their lives. The shared knowledge fits into the process by which the problem is identified. So potentially a diagnosis is made if the person doesn't already arrive with a diagnostic label. It also affects the choice of support or treatment that can be made during the interaction. And we saw that very clearly in the interaction. If the eating disorder problem is not considered to be a serious problem, then no further support is offered. Agential epistemic injustice may prevent a genuine exchange of information from happening because the people seeking support share their experiences, but healthcare practitioners may not take them at face value or further explore them, and this potentially leads to premature labeling. So when we were working with young people with lived experience of mental health in analyzing these interactions, they were never against diagnosis as such. Many thought the diagnosis was really helpful for accessing support and for understanding what was happening to them a little bit better. But they were against premature labeling. They thought that sometimes they were seeing someone for the first time and they would be told in the first few minutes whether they were depressed or whether they had an anxiety problem without their experiences being actually listened to. So suggestions for further support and treatment based on partial or distorted information about the experiences of the person seeking support may turn out to be misguided or ineffective. So the goals of understanding the nature of the problem and identifying the best means of support, goals A and B, are less likely to be met if we've got a case of interaction that doesn't explore the experiences of the people seeking support. So when we went back to Patrick and Sasha, what did we learn about their cases? So over the next 3 months after the visit to emergency services, Patrick returned to emergency services twice, once for suicidal ideation and once for a pharmaceutical overdose with suicidal intent. In his 3-month post-visit interview, Patrick reported that he would not have gone to emergency services again after his first encounter, but was brought back by the university counseling services. So we know that Patrick overdosed 3 months after. Sasha did not receive a referral for specialist eating disorder services when she visited emergency services, but after that, she was encouraged by her parents to continue seek specialist support and began treatment with an eating disorder specialist 3 months later. By then, she had lost a substantial amount of weight, and she reported, I did get the impression that people weren't taking me seriously because I still looked vaguely normal. I've lost even more weight since then, so I kind of firmly within the anorexic range now. So I think, I don't know, maybe if I'd been able to access help sooner, then you wouldn't have got to that stage. Okay, so nobody can know the future, right? The healthcare practitioner visiting Patrick and Sasha couldn't have known that, you know, they would have needed more support to avoid these kind of unpleasant consequences. But I think what we can reflect on more helpfully is that neither Patrick or Sasha thought that the support that were offered was adequate to the severity of their situation. And potentially, I think from reading the full transcript of the interaction, their experiences were not taken seriously or investigated. So Patrick overdosed a few weeks after his first visit to emergency services, and Sasha continued to lose weight. And their visit to emergency services did not make them feel listened to or taken seriously. And this leads us to the second argument, the motivation argument. Is it important that you feel like you're taken seriously during the interaction? Or is it just something that makes you feel mildly better but has no medical consequences? Well, I think it has medical consequences, because part of the idea of the interaction is that someone proposes to you some changes to your lifestyle or some medication or some therapy that then you go on either complying with or not complying with. And whether you think that's the good thing for you to be able to do in order to improve your health journey will depend on whether you feel that you've been listened to. And you have to say in whether that was the right support for you at that time. So our social interactions have a powerful effect on our sense of agency, especially when our sense of agency is very threatened, as when we are vulnerable, as in a mental health crisis. Successful interactions where we feel that we are listened to and understood, where our contributions are valued, make us feel like competent agents who exercise the capacity to genuinely participate in a shared epistemic project. But both in the optimism literature, optimism bias literature, and hope theory suggest two components to goal pursuit and achievement. There is a cognitive component, which involves perceiving ourselves as capable of pursuing the goal and perceiving the goal as desirable and achievable without downplaying difficulties. And there is a motivational component, supporting our motivation to pursue the goal in face of potential difficulties. And these interact all the time. And it's very difficult for people to be able to say, okay, I'm going to try and fix this, unless there is a motivational component that has to do with the sense that people have that they can intervene in the world and contribute to positive change. When we experience a mental health crisis, there is a threat to our sense of agency already that is due either to the nature of our symptoms or the self-doubt and stigma that is triggered by the adverse reactions that we find in society to our mental health conditions. So low mood, unusual experiences, paranoid thoughts can affect the way we see the world, presenting it as less predictable, but also presenting us as less able to manage it, less able to make a difference in what happens to us. And indeed, the sensation of helplessness is the most transdiagnostic experience of all, like in all kinds of mental health conditions, even if they present very differently. The sense that things are happening to you that you're not in charge of is really strong. So these experiences can make us feel helpless, as if we are entirely lacking control, and being excluded from social interactions due to being perceived as dangerous or incompetent can further undermine our sense of agency. So what I'm trying to suggest is here we have an age range, 16 to 25, where people are particularly vulnerable because they are in a transition, going from school to university or from school to work, and changing their reference from their parents maybe to their peers, living all of these transitions that make them feel a bit less stable in their identity. In addition to that, they've got a mental health crisis that make them doubt themselves and feel helpless. What we don't need is another reason to challenge the sense of agency by not being listened to and not having their concerns legitimized in the healthcare context. So the idea is that clinical encounters can sometimes increase the sense of disempowerment that is already there. In interactions with emergency services for suicidal thoughts and low mood, young people are often interrupted, dismissed, patronized, or challenged. We just saw a couple of examples. And in the context of psychosis, personality disorders, and dementia, just considered a lot more serious in some respects. People describe experiences in clinical encounters as infantilizing and dehumanizing. So in epistemically unjust interactions, we are made to doubt our own perspective, and our contributions to the exchange are dismissed or reinterpreted, and this undermines our sense of agency, both in cognitive and motivational components, the idea that I can achieve my goals and that the goal is worth going for. And this interferes with one of the aims of the interaction, which is to enable the patient to contribute positively to restoring or improve their health. Without the patient contribution, no offer of support or medication or therapy is useful, because there could be lack of compliance. And in many of the cases that we saw, that was exactly what happened. So people were coming back to emergency services because some suggestions had been made to them, but they had not been explained or motivated, or they were not made to feel like they could achieve anything through those interventions, and so they did not make an impact on their lives. So, conclusions. If healthcare practitioners do not take patients' contributions at face value and explore their significance with curiosity and empathy, then there is no shared knowledge on which to base either the diagnosis or the selection of adequate means of support. Taking at face value and exploring doesn't mean believing exactly, everything that the patient tells you, and kind of building a kind of intersubjective space where you think that the experience of the person is exactly as I described. That's not required. This step towards credibility is not required. What is required is taking them seriously enough that you think it is a genuine epistemic contribution and deserves maybe to be challenged also, but you have to explore it before you can challenge it. If you challenge it before you have explored it, what happens is that the young person is withdrawn, stops sharing information, and that information that could be shared is no longer available to the practitioner to make diagnostic decisions and other types of decisions as part of the encounter. Even more important, if the healthcare practitioner does not acknowledge that people seeking support are agents with valuable perspective to share and with the capacity to contribute to positive change and participate in decision making, people's sense of agency may be threatened not just by the mental health crisis or other things that are going on in their lives, but also by the nature of the healthcare interactions that they experience, which then leads them not to seek help in the future, which is something that a very strong pattern that we saw when the interactions were not good interactions, successful interactions. The young person either said, I will not come back here, or we know from their future records that they did not willingly access the services anymore, which means that support that may be available to young people is actually not actually available to them. So this undermines the motivation to trust healthcare professionals, follow their advice, seek further support when needed, and comply with medication. So agential epistemic injustice prevents speakers from making a genuine epistemic contribution to an interaction and compromises the fulfillment of those goals that depend on such a contribution. What are the implications? Well, I think it is a mistake to interpret calls for a more epistemically just medical practice as yet another demand to be made of healthcare professionals, something that may distract them from their real job or even undermine their attempts to improve the health outcomes of people seeking support. I think we can make exactly the opposite argument, that epistemic justice contributes positively to improving health prospects. And also, we shouldn't think that this is just doctor bashing. This kind of arguments can be made for an interaction where you've got a power imbalance. As I said, teacher-student, parent-child, employer-employee. I think it's in all of those cases we can see how behaviors that can be interpreted as instances of epistemic injustice may prevent genuine epistemic contributions to be made, and therefore may actually make the goals of that specific interaction less likely to be fulfilled. Thank you very much.